Welcome to Psych for Psychology, a Nystrom & Associates podcast. Our host, Brett Cushing, is a licensed marriage and family therapist at Nystrom. Each week, he talks about all things mental health and therapy with guests, and you get a chance to dive into specific psychology topics that help promote personal development and wellness. And now, your host, Brett.
Hi, everybody. Welcome back to another episode of Psyched for Psychology. My name is Krista. I'm a marriage and family therapist. I'm here with my trusty sidekick, Brett Cushing, who is also a marriage and family therapist. And we have a special guest with us today, Emily Connery, who is a psychotherapist at the Hugo Clinic here at Nystrom & Associates. And she's going to be talking with us about I have a couple acronyms coming at you, some letters. Okay, so we're going to talk about OCD, which is Obsessive Compulsive Disorder, and one of the treatments for this disorder, which is ERP, Exposure Response Prevention.
You got it.
Woo, okay, no pressure. So I think, we're excited to have Emily here today. And yeah, we were just actually, before we started recording, we were just reiterating kind of why do we do what we do? Why do we do this podcast? And we want therapy and mental health to be approachable. And so I'm really excited that Emily agreed to kind of break down some of these acronyms for us. There's so many acronyms in mental health.
And this is one of them. OCD, I think, is one of them that people are very familiar with and sort of do this armchair diagnosing, either of others or themselves, right? And they'll say, that person is so OCD, or I'm so OCD. And so we have this idea of obsessive compulsive disorder, and it's not always real accurate. So we're hoping you can help us all out, understand what is OCD, and you know, when does it actually become OCD? So welcome, and maybe you can jump in telling us a little bit about that.
I'd love to. Thank you guys for having me. I'm very excited to talk with our listeners today about those acronyms and just my passion for treating OCD. So this is great. So yeah, we were talking about how we first need to understand what OCD is and some of the misconceptions out there before we can go into the treatment aspect of it. So OCD, Obsessive Compulsive Disorder, is a diagnosis that really you have to have two parts. You have to have what we call obsessions and you have to have compulsions. So I'm first going to go into what an obsession might look like. So these are recurrent, meaning they come pretty consistently. They're intrusive images or impulses. They're not excessive worries about everyday life. So if you're worrying about like family, friends, health, your finances, that's not really what we're looking for. We're looking for more things that are distressing and intrusive. They're not really consistent with your values as a person. They're kind of like, whoa, like, where did that come from? I don't like that thought. That's really distressing to me. And because they're so distressing and unwanted, people try to resist them or get rid of them or reduce that distress in some way. And so that's where the compulsions come in. So then people have kind of associated or paired or learned how to do certain things in their life to get rid of that anxiety. So we talk about compulsions, then we're really moving into like a behavior or a mental act that a person feels driven or compulsed to perform over and over again to prevent or reduce anxiety. Sometimes it can be to prevent something bad from happening. So that like, if I don't do this certain thing or don't think this certain thing, my family might get hurt or something terrible or catastrophic might happen in my future.
Sure.
So yeah, the compulsions are often performed in response to the obsessions.
Okay.
So the obsessions, then, this is more thoughts that result in compulsive kind of behaviors.
Right.
And is it correct to say that these obsessions are thoughts that just sort of come our way? We don't really have control of them coming. You said intrusive thoughts. Are we just unable to prevent this from happening in the first place? And we're just sort of, oh man, here it comes again. And is that kind of what you're saying?
Yeah, I think I can certainly normalize that every human has intrusive thoughts from time to time. Like we all are like, hey, that dog's really cute over there. I'm really attracted to that dog. And you're like, what? Like, what, you know, like, what does that mean? Like, and then most people are able to just be like, that was weird, and like move on with their day.
Mm-hmm.
People who have a predilection towards OCD or have more of a sticky brain really mull on those thoughts and go, oh, that was weird. What does that mean? Oh my gosh, what if I'm attracted to dogs? Like, what if what if I'm actually going to harm a family member? Like, what if I harm my baby, right? There's like some self-harm obsession.
Really interesting, because I heard the word you said a couple times, what if? What if? Very much kind of future-oriented, this anticipatory anxiety.
Sure.
Do you find that happens a lot for people with their obsessions? Is it more the kind of manifesting in that future orientation, what if?
I think yes, and I think it's they're just over analyzing the thoughts that are happening, and don't know how to get it out of their head, and the thoughts become very over consuming to them. This just gets stuck. Things just get stuck. And we're ruminating on those thoughts and analyzing them to the point where it's very distressing to the person. And then the more that we think about something, I think the more power we give it. And so those thoughts are more likely to stick around and come back, rather than the average person who can maybe be like, that was weird, and move on and do a different task and don't think anything of it. I don't know if I answered your question.
Well, so no, I am an examples person. My clients all know if they tell me something, I'm like, well, do you have an example of that? Right. So I think it'd be helpful, with, you know, there's the two parts, like the obsession and then the action that comes after the compulsion. What would be an example of an obsession that someone has? Because I think we all have, again, just different stereotypes in our heads. Like the person who, I think the one that's portrayed a lot in film is hand washing.
Yes.
And the clean and germophobia. So any thoughts on an example of an obsession?
Yeah, I have some examples that I can certainly share with everyone. So contamination, I think you're right, is like I'm going to call it the classic, right? The classic example where someone's very much afraid of germs, sticky substances, public bathrooms, chemicals, that sort of thing. There's also obsessions called fear of harm or danger, where people become or have intrusive thoughts about, I might harm myself or I might harm another person. And that gets into a tricky area when we talk about suicidal ideation, but how I delineate like the intrusiveness part from it, from like actually having suicidal ideation, is that the person doesn't want to harm themselves. It's not consistent with their mood and their affect, nor is it consistent with their values as a person. So they're like, I don't want to like look at that knife and think that I'm going to harm my family member. It's just like, I have a thought that pops into my head and then I get really scared that because I have the thought, that means I'm going to go through with it. So there's sort of this magical thinking of like, if I have a thought, that means it's going to come into fruition. And so that association becomes very like clear for them, which isn't always the case. So that's another example. Fear of loss. So people who might really be afraid of not remembering something, misplacing something, and then will, of course, make excessive notes or do some hoarding. So that's another example. Some people might need a need for symmetry or order. So having things just
That's me,
is it?
Yeah. Oh, symmetry and order. I need it. That's how I manage my ADHD. I just have to have symmetry and order. So, but we're going to talk about that in a little bit. Like,
that doesn't
I want to put this on the radar. Like, that doesn't mean I'm OCD, right?
Yes.
Okay.
Right. Yeah, it's so hard to distinguish between someone's personality and like needing things just so, and like when does this become clinical? Like when is this problematic? So we can certainly talk about that. But there are people out there who like, the perfectionism is so strong that it interferes with their ability to do their daily life, right? Like to be a parent, to work, to have social skills, things like that. So we're really talking about like impairment when we're talking about when does it become?
Those are great examples. But that's really helpful. I'm wondering, you're probably about to, but compulsion, right?
Let's switch, right?
So for every obsession there's usually a corresponding compulsion with OCD.
Absolutely. Yeah. So we talked about contamination. I would say the biggest compulsion we see paired with that is the washing and cleaning. So we're talking excessive hand washing, excessive grooming, excessive toilet routine. excessive brushing teeth, cleaning things, checking. I would say if there's one compulsion that I had to choose that is most common that I see, it's a checking compulsion.
What would be an example?
Yeah, like checking the stove multiple times or a certain number of times or until it feels just right. Light switches, door locks. We even have something called reassurance seeking that kind of falls underneath the checking category, where you're asking another person for reassurance in a non-functional way. So it's not that you're seeking information to make a decision.
Yep.
You're seeking information to have your anxiety lessened. And so that's how I differentiate between information seeking and reassurance seeking. So it could be things like, I locked the door, right? Or you still love me, right? Or...
And asking that over and over, right? So it's like you already have been told the answer.
Correct.
But the idea is if I ask it again, maybe I'll be less anxious. Right?
Yep. You're really seeking a desired answer. You're not seeking the truth.
Sure. Okay, that's helpful to know too. It's like you're wanting that answer that's going to make you feel better.
Yeah. You already know kind of what you need from the person. You just need to ask it over and over again.
Yep.
But you're never really getting the answer that you want because there's so much uncertainty in life. So then people feel like they need to keep asking. And so it becomes a compulsive sort of behavior.
Okay.
And again, anxiety is a big part of this. And so it's to reduce that sense of anxiety, that sense of vulnerability that people have. Now, I'm sure people are listening and they're saying, well, I do obsessive things. I do compulsive things. If my kid doesn't come home, I'm, pacing and looking out the window to try to alleviate my anxiety. That's a behavior. So how do I know I don't have OCD? How do we know when it becomes, like you said, clinical, or concerning?
I would say if the person is noticing that the thoughts are starting to become consuming or the behaviors are consuming to the point where, again, they're struggling to get their work done, or family members or friends are noticing like, hey, something's up, like you're just not as flexible as you used to be. You really need things to be a certain way and you can't go outside of that box that you've put yourself in. And it's distressing to the person. I think that's an important piece of like, therapy is this distressing to you? Is this something that you feel like you need to get worked on? Or
do you find people who have OCD, they are aware of it and they are receptive to people telling them, or are they just sort of unaware and resistant? People tell them and they get defensive. What do you find?
I actually find that most people with OCD are pretty aware of the symptoms and how debilitating they can be, and are generally open to seeking help because they're just sick of this ping-ponging between having the obsession and feeling the need to do the compulsion. The more we do the compulsions, the more the obsessions are reinforced. And so it's this really difficult cycle to get out of unless you're seeking treatment for it.
Wow.
Sure. Probably difficult to get out of on your own, right? I'm sure people try all sorts of different things by themselves or kind of on their own. By the time they get to you, they've tried, I don't know, maybe they've tried multiple different things to get themselves out of it. But
yeah. I just, I think for OCD, talk therapy, in my opinion, is just not going to cut it.
That's that's good to know.
So,
why not?
Yeah, exactly.
Because for me, ERP is all about behavior change. And when we're just talking about the obsessions of of course we can normalize that OCD this is a disorder. It's not just something to be ashamed of. Like, I'm so glad you came in and got help. Like, I can certainly validate their experience, but we're not breaking that association between the obsessions and the compulsions unless we're doing the ERP work, which is all about behavior change. That's all it is.
So I'll just chime in there too, because I think this is a good distinction. So Emily just said talk therapy. And what we mean by talk therapy is kind of like therapy as usual, right? Like you come in, you talk it through with a therapist, it's more on that cognitive and sometimes even like philosophical level and analyzing patterns. But what you're saying is unless you're really getting into behavior change, it's for OCD in particular, that's where the game changer happens.
Absolutely.
Yeah,
we really need to know what are the obsessions, what are the compulsions, and I'm really going to focus on the response prevention part.
Okay.
So what are we doing to stop the compulsions from happening? Because ultimately that's going to help the obsessions get better. Ooh. So parts of this are feeling like it feels a little counterintuitive at times for people, but it's a really neat process.
Well, so let's break it down. So we have ERP. So which one of those letters do you think would be, what is the helpful way to kind of break this down?
Yeah, I would say we can start with the E. So the exposure component of ERP refers to practicing confronting the thoughts, images, situations that make you anxious or whatever provokes your obsessions.
Okay.
So I'll use a contamination example because that's one that most people can understand.
Yep.
I am very much afraid, I'm going to say I and use an example. I'm very much afraid of using a public restroom because of all the germs and how I think about how many people have gone in there. Has this been cleaned? Mm-hmm. And so I might ask a client of mine to, touch a doorknob going into the public restroom just as a starting point. And again, this is a very collaborative approach. So we're going to start somewhere that the client feels comfortable. For some people, that might be too easy. For some people, that might be very difficult. Too hard. Yeah. So that's the exposure part, right? Because we're eliciting that obsession of, oh my gosh, there are so many germs right now in this bathroom. I don't know how I'm going to go in there.
Okay.
So then when we talk about the response prevention part, that refers to you're making a choice to not do a compulsive behavior once the anxiety, their obsessions have been triggered. So usually for that person, they're touching the doorknob and they might be able to do that with some anxiety, but then they're going to go wash their hands 15 times
Which
or
is the
use
compulsion.
15 pumps of soap. Yep. Or wash until it feels just right. Maybe there's not a number that they're going for, but it just has to, they have to like reset and feel good about it. And so that's when they'll stop washing their hands.
Right.
And people's hands can get super raw and it causes a lot of issues and they're spending a lot of time in the bathroom.
Right.
So like I said, all of this is done under the guidance of a therapist, kind of creating a hierarchy of like where can we start? Where can we work up to so that we're not flooding you with ton of anxiety at the beginning, but we're eventually going to work up to the hard stuff. But the cool thing about that is that once we get to the hard stuff, it won't seem as hard because you've done all the stuff below that. So you've been inundated with the anxiety. You're getting better at managing it. It's not going to seem as bad.
You said something I think is really profound, and I wanted to highlight because I find in our culture anxiety bad, so we move away. And I always tell my clients, lean into your anxiety. We don't want to avoid it. Mm-hmm. And what I heard you say earlier, that can reinforce it. And the words you said were inundated with anxiety. Wow, that sounds kind of scary and daunting. Yeah. And I love it because there's, to quote that book we've referred to here on the podcast, The Wisdom of Anxiety. There's some wisdom you're talking about here of leaning into that and being inundated with the anxiety. Mm-hmm. That's the path through this in some ways. That's the exposure piece. So that's fantastic. I love this. And it's easy for me to say because I don't have to do it. So,
right.
So tell us more then, like what's happening and what's it like for people who go through this exposure piece?
Yeah, I think the scary piece, as you said, Brett, is the exposure part, right? Like I do not want to do anything to make my anxiety worse. I'm already living with it, suffering from it. And so I would say, yes, there is going to be a certain initial increase in anxiety because the person has spent so much time avoiding it. But clearly that's not working either, right? So we got to figure out a different way to approach it because avoidance it's just going to make things worse in the long term. In the short term, avoidance feels great, right? I pulled that emergency brake. My parachute is out. I am out the door. I don't have to face it. Yep. So short term, it's very positively reinforcing to avoid a situation or something that makes you anxious.
Mm-hmm. Sure.
Long term, we're going to have to face it, but we can do that in increments. We don't have to, I think inundate is a scary word, right? Because like, I don't want clients to think again that I'm going to flood them with anxiety, but they're going to feel an initial increase just because they are facing something that they've initially avoided. Sure. But I think the cool thing is that, that increase is only short term. And I've heard from a lot of clients that they feel such a sense of relief and productivity, because they found a therapy that's very structured, behaviorally based. It feels progressive. They feel like they're moving forward. They have a plan, and that collaboration and that support along the way to do this treatment is really incredible.
So this is so interesting. One question that I have is, are you actually like in a session with the example that you gave of the doorknob, we'll say. Mm-hmm. So are you going with your client or your patient walking over to the bathroom door like as part of the session, or are you assigning that as like, this is your homework between sessions?
I would say both.
Okay.
I've done a lot of work in the past at previous positions of actually going and doing the exposure with the client, because I really want them to have a great foundation of knowledge of how do I do this? What is this going to look like? Here, I have a support person with me.
Yeah.
Confidence in this and buy-in into this treatment is so important for my practice, because I need people to believe that it will work. I need people to see that it will work. Mm-hmm. And unless I'm with them doing it, I can't, they may avoid it, because it's hard.
Absolutely.
So if I can give them a little taste of it in our sessions, absolutely. I think that's the best way to go. And then I will assign them homework as well for things to do on their own.
Sure.
There are some examples of exposures that don't require me to go and do something with the client. It might be just like imagining something happening, right? We can do imaginal exposures. Visual. Yeah. We can do things where we write things down on a piece of paper that might be scary, and they just kind of have to look at that statement or that word even, or that number even.
Wow.
And that is enough to elicit anxiety. So it doesn't have to be incredibly hands-on. There's a lot of different tactics that we can use in interventions together.
That's helpful, because, and it also sounds like these things you're doing aren't just like right away first session. Like, you're building the trust with that person. You're understanding what are their obsessions, what are their compulsions. So I don't want anyone listening to think like, okay, I'm going to go to, do this ERP and my therapist is going to have me touch doorknobs the first session. Like, this is a process, right?
Yeah.
I'm also glad you mentioned that about the having clients imagine things, because earlier you said that a compulsion can be a mental act, right? Mm-hmm. So I'm trying to think of a good example of that. Like
a prayer.
A prayer, okay.
Or a mantra that needs to be said just right until they start to feel better.
Okay, and that can be said kind of in your head, right? Mm-hmm. Okay.
Yeah, so that's why it's so collaborative, because a lot of people don't even realize the things that they're doing function as a way to lessen their anxiety. And so going through, like, to refer back to your point, Krista, like, I would say we probably don't get to exposures really until the 4th or 5th session.
Okay,
because we're doing the initial assessment. I'm building rapport. I'm see this packet that I have in front of me. Like, I'm going through this with clients. Like, here's what it's going to look like.
Nice.
Here's visuals.
You really
like,
spell it out.
I really need clients to understand what they're getting into, in a sense, too. So
I would imagine when you assign homework to people who understandably are avoiding.
Correct.
So I can also imagine people, they come in, they didn't do their homework because they want to avoid, and you're like, what do you just yell at them then when they come in?
Yes, I'm so mean.
Yes,
yeah.
You seem terrified.
Yeah, I'm just, I'm like, I would never have any clients come back, right? Like, that's not the way to go about doing it.
So what happens? How does, because I can see people saying, I don't see myself ever doing the homework. What hope is there for them? Because they might be thinking, no way I'm doing this homework, and I'm sure you run into that. So how do you handle that?
Yeah, identifying the barriers, why didn't it get done? Just being very curious about it. I would say that most of the time the avoidance is coming from the exposures are too difficult.
Okay.
So I have people rate what an exposure, what their peak anxiety might get to during an example exposure. So I'm like, Betty, you're going to touch this doorknob. What do you think your anxiety might get to? And I use a 0 to 7 scale. 7 is panic attack, 0 is calm. And they might say, oh, you know what? Like, I haven't done that yet. That seems really scary. That might be a 5. And I write down 5. When we eventually get to that exposure, sometimes it's less than what they expected their anxiety to be, and sometimes it's more. So when people are avoiding their exposures, I often assume, was this a little bit harder for you than we had initially anticipated? Yeah. Let's figure out a way to like decrease the anxiety for you.
Just meet them where they are.
Yeah, it's just about identifying barriers.
And assuming that there's a good reason for it, right? It's like you're not assuming like, oh, you just were avoiding it, you're not up for the task. It's like, there's probably something we can learn in here, which in this example would be, this was maybe way harder than you thought it was going to be, right?
Yeah, and I have to assume that if clients have stuck with me for 4 or 5 sessions, that they're in it, you know? Point. And so if there's something that's happening in session 5 and 6 and it's not working out, it's like, it's not due to their lack of motivation or anything like that. I think it's just we got to finagle some things around.
Mm-hmm. Totally. The other thing I was thinking about that probably comes up when you're doing this therapy with people is, you had mentioned one of the, I can't remember. Oh, a compulsion of reassurance seeking. Mm-hmm. That's a compulsion, right?
Yeah.
Okay.
Yeah.
So do you ever notice your clients seeking your reassurance? Mm-hmm. And then if so, how do you handle that? Because you're probably like, ooh, I don't want to play into this, right?
Yeah.
Yeah.
It's so hard. Yeah, it's so hard, Krista, because we're therapists, right? We want to be helpers. We want to make people feel better. And some people are so sneaky about getting reassurance.
Of course.
And they're really good at it. And they've learned how to sneak it into conversation so you're not noticing it and things like that. So I'm guilty, I'm sure, of reassuring my clients. I just am, you know, but I try to just be direct with them. Like, okay, are you seeking this information because you wanted to make a decision right now? Or like, that kind of seems like reassurance to me. You know, what do you think? And I have never had a client that's gotten defensive about that. Mm-hmm. Like, they're like, oh, yep. I'm anxious right now. I need you to tell me to feel better.
Awesome
you know,
stuff. That's
like
so good.
Wow. So it sounds like they might not even realize that they're necessarily doing a compulsion right then.
Right.
Because then when you point it out, it sounds like by and large they're saying, oh, actually, yep. That totally was.
Yeah.
And I am anxious right now.
Yeah.
So you're pointing to, what are you feeling right now? Right.
Yeah. I mean, it's such a part of I would have to assume part of their routine. Mm-hmm. You know, it's automatic. And we're really trying to take things off autopilot and think about, what is the function of this for you right now? Is there a way that we can reduce that to help you feel better?
Sure.
And as I listen to you, what I like so much about what you're saying is the balance. I'm all about balance. And I think therapy in general is going to be characterized by a balance of validation, acceptance, and change. Mm-hmm. And when I hear people get frustrated about therapy, it's one of two things. It's all my therapist did was validate me. Yes. And I really never got anywhere. And I've also heard people say my therapist just kept pushing me and pushing, but they didn't have any validation. And as I'm listening to Emily, I hear you start with a lot of validation, a lot of acceptance, and there's an emphasis on change, and you have a good balance. Really like what you said, Krista, assuming there's a reason. Mm-hmm. Assuming a reason. And I think that is such a validating thing. And I hope people that are listening who are struggling with this and people who live with somebody who struggles with this are hearing that when you come in for this kind of therapy, we are starting at a point where we assume there's a real good reason why this is going on. It makes sense. So it starts with a lot of validation, and that's our assumption.
Mm-hmm. I love that. That balance is really tricky to find, especially when you're doing a very behavioral based approach. And that's really what I strive for. Of like, hey, listen, this has been really tough for you. Like, I can't imagine living with this, and like, I'm so glad you came in. Like, let's talk about how this makes you feel, right? How has this been affecting your life? And let's talk about change. Yeah. So that's like, I think that's just a sweet spot for therapists to manage of being understanding, but also then talking about where do we go from here? Right? What do you want to get out of this?
Well, I'm thinking about where do we go from here with our closing minutes. We still have the R&P to talk about. So can you talk about the R&P?
Yeah, so the response prevention part, like I said, was making that choice to not do the compulsive behavior once the obsession has been triggered. Mm-hmm. So we're going to reduce things like checking, reassurance seeking, what are some of the ones I listed?
So we're triggering the obsession on purpose. Like we're prompting the person
exactly
to, or maybe the compulsion. Are we triggering the compulsion on
We're
purpose?
triggering the obsession on purpose,
Okay.
and then reducing or stopping how much we're doing the compulsion.
Sure. Got it.
So we're really helping people sit with distress. That's really the heart of ERP, I would say. We call it habituation, which is a fancy way of watching our anxiety go down without us having to do anything about it.
Wow.
So like a natural curve, right? We picture what a natural curve looks like, that nice little bell.
Yep.
So most people, before their anxiety gets bad, are going to bail out, right?
Like,
and get out of the situation.
Yep.
Pull that parachute, you know?
Yep.
And so they never learn that there's this whole other side to the curve where, yes, their anxiety might have gotten a little bit worse, but it gets better. And we want clients to see the other side and build confidence that they can manage whatever anxiety comes up. Again, not in a flooding way, but just in a manageable way. And then they don't have to do the compulsion. We're really breaking that association for them.
That image that you said about the bell curve is so helpful, because what I was picturing is basically that I've learned, someone with OCD, I've learned that I can bail on the curve by doing my behaviors or doing my mental act or whatever it is. What they don't realize is if I stick it out, yes, it could get more intense. It probably will. But look how it's going to come right back down without me doing anything, right?
Yeah.
With me using a different way.
Freedom.
Right?
Freedom from the compulsion is our ultimate goal, which then is going to make those obsessions become less and less and less frequent and intense and healing,
Yep.
So this is... Oh, sorry. Go ahead.
Oh, no. I was just going to say, so it sounds like the RP, the response prevention, is we're working on not doing the same thing that we've been unsuccessfully trying to do.
Yeah.
Right?
Right.
Yeah.
It just hasn't worked out.
Right. Yep.
I think this is profound because we live in a culture where distress tolerance, tolerating distress is kind of like, it's not a value, it's a faux pas in our culture of immediate gratification.
Yes.
Because we can self-medicate through a chemical, through something behavioral. I can go on social media, I can go on my phone, porn, I can go on my phone, I can go to food. All these things. And I really think of the people who go through this, and this isn't just a skill to deal with OCD. This is a skill for life that we can learn. I don't have to act out impulsively to deal with some distress that I have. I don't have to self-medicate it in some way. So it's a wonderful skill that we can generalize too.
I'm so glad you brought that up, because ERP itself is for OCD, but there are elements of ERP that we can use for generalized anxiety, social phobia, panic disorder. It's really expansive. And so that's what I like about it, because we can take elements to treat other anxiety disorders. It's all about being more flexible and tolerant of uncertainty too. I would say that's the takeaway that I've learned as well. People who struggle with anxiety have an allergy to uncertainty. And so we can help people become more tolerant of that. Like you said, instant gratification. I can go on my phone, check when my Amazon package is coming to a T, check the weather, GPS my way to the new place I'm going, find out where the parking is ahead of time, right? There's no uncertainty in our culture anymore, right? We're so inundated with information, to use that word again.
It's true, no.
Right. So I think as a culture, we're kind of moving towards being more intolerant of uncertainty, because we don't have to sit with it. We don't.
I think this is so encouraging. It's very tangible, and you said very behavioral. And I'm so glad you hear this. Is such a relevant topic on multiple levels, and it's evident that you're very competent in this, and I'm very assured that you are value added here at the Hugo Clinic. And this has been value added, I think, for people who are listening. So thank you so much,
Emily. Thank you guys.
We really appreciate this.
And if I could plug just one more thing.
Yes.
So if people are interested to learn more information about OCD, there is a wonderful website called the IOCDF organization. So it's IOCDF.org is a website. I'm on there as a provider if people want to find me to do some ERP work. There's tons of resources, conferences, support groups. It's a great resource for everyone. And then a book that I've really, really liked, not only as a clinician, a therapist, but a lot of my clients have read it and said, Emily, like, this book was written about my life. Like, this is so great. So it's called Needing to Know for Sure, a CBT-based guide to overcoming compulsive checking and reassurance seeking. And its application not only for OCD, but generalized anxiety disorder and other things as well. And it's by Martin. I have authors too written there, but
I'm sorry, I took that from you.
Oh, that's okay.
Sally Winston and Martin Seif. We'll see if we can put those in our episode notes too as resources for people.
Great.
Yeah, thank you. I'm so glad
I mentioned those.
So again, if you want to learn more about OCD and ERP, go ASAP to IOCOF.org. Right?
IOCDF.
IOCDF.
Yes.
Oh boy. Okay. Thank you. Appreciate that, and we appreciate everybody listening with us. Emily, thanks again.
Thank you.
And we'll talk to you next time on Psyched for Psychology.
Thank you as always for listening, and please be sure to leave us a review. While this podcast can't be a replacement for therapy, we hope you enjoyed our discussion today and join us again next time. Nystrom & Associates is always available to those who are struggling. If you find yourself in need of support and help, please check us out at nystromcounseling.com.